Mitu Shrikande, Hemato-oncologist at Fortis Hospital, Vasant Kunj, New Delhi. September is universally celebrated as the Blood Cancer Awareness Month. And as a part of these celebrations, we hematologists take it on us to create awareness among the public regarding the blood cancers. This Connect today is dedicated to all the blood cancer patients out there who have been fighting or have fought like true heroes. What is blood cancers? Basically, it comprises of three broad categories, which include leukemias, lymphomas, and multiple myelomas. Blood cancers are potentially curable. I'm here today trying to share this hope of cure with all of you. Today, we shall be talking about one of the commonest blood cancers, which is lymphoma. Now, what is lymphoma? Lymphoma, the meaning lies within the word. If you split the word, oma means a mass, and lymph refers to the lymphoid tissue, which is the cell of origin. So, lymphoid cancer or lymphoid masses are known as lymphoma. Now, what is a lymphoid tissue? I'm sure many of you will have that question in your mind. So it is the tissue that produces, stores, and carries lymphocytes. Now, what are lymphocytes? They are a type of white blood cell, and they are the building blocks of our immune system. So lymphoma is the tumor of the immune system. Now, what does lymphoid tissue consist of? It consists of lymph nodes, but that's not all. It consists of, in addition to lymph nodes, also the bone marrow, the spleen, the thymus, and also the mucosa associated lymphoid tissue. The next question arises that what are the types of lymphoma? So we have about 90 categories of lymphomas, but if we were to broadly categorize them, they are divided into two broad categories: Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma again has various subtypes, but most of them are, 95% of them are clubbed under a category which is known as the classical Hodgkin's lymphoma, which is constituting nearly 95% of all the Hodgkin's, and they're treated in a particular manner. There's a 5% category, less common, which is known as the nodular lymphocytic predominant Hodgkin's lymphoma, which is treated differently, yet it is a Hodgkin's lymphoma. Now, what is more common among the lymphomas is the non-Hodgkin's lymphoma. Now, non-Hodgkin's lymphoma again can be broadly categorized into T-cell non-Hodgkin lymphoma and B-cell non-Hodgkin lymphoma, depending on the subset of lymphocytes where it comes from. If it is coming from T lymphocytes, it's a T non-Hodgkin cell lymphoma. And if it's a B lymphocyte where it is originating from, then it's a B type of non-Hodgkin's lymphoma. Now, B-cell lymphomas, non-Hodgkin lymphomas, can be further categorized into aggressive or indolent based on how quickly they progress. Now, aggressive lymphomas are very, very progressive, and they come with aggression, as the name indicates. Now, most common out of these aggressive B-cell non-Hodgkin lymphoma is the diffuse large B-cell lymphoma. The others being Burkitt's lymphoma and mantle cell lymphoma, which are less common, but they're very aggressive. Among the indolent non-Hodgkin's lymphoma, the commonest is follicular lymphoma, followed by chronic lymphocytic leukemia or small lymphocytic lymphoma. And then we have the marginal zone lymphomas, Waldenstrom macroglobulinemia, and many others. Now, what are the symptoms of lymphoma? The most common symptoms are swollen lymph glands or lumps, which are typically seen in the neck or in the armpit or in the groin. Now, these all could be there in isolation, or they could be all glands could be enlarged at all these sites. Now, usually the hallmark is these glands are painless. So these lumps will be there, but there is no pain. What are the additional symptoms? These additional symptoms are non-specific, and they are also typically known as the B symptoms, which includes unexplained fatigue, or they could be drenching night sweats, and the patient sleeps and complains that he gets up in the middle of the night and he's totally wet, and he's, the clothes have become wet, so much so that he needs to change it. Then there could be persistent fever. Now anyone can get fever, and I keep telling all my patients, anybody can get fever, but it's a persistent unexplained fever lasting more than 1 week, maybe more, which is not explained due to common seasonal infections or any cause, no cause found. Now, it's important to remember that though lymph node enlargement is very sine qua non or the most presenting symptom of lymphomas in general, it is the swollen lymph nodes are not always due to the lymphoma. It's in fact more commonly due to some infection, because lymph node enlargement is a body's natural response in fighting any infection. It is a persistently enlarged lymph node or progressive enlargement of the lymph nodes, which is more critical and points towards a diagnosis of lymphoma. Now, many of these symptoms of lymphoma are caused by less serious illness, and I do not want to cause any public scare by mentioning all these. As I said, any combination of these symptoms and unexplained persistent symptoms which I've mentioned are then suggestive of a lymphoma. Now, lymphomas can occur at any site. As I mentioned, that lymphatic channels are there all over the body. So it can, depending on the organ involved sometimes, or the site and the size of the disease involved, the symptoms can be different. So suppose sometimes they very rarely can be there in the stomach or intestine, and they can present with bleeding in the stools, or it could be obstruction in the intestinal tract, and these could present in that manner. And sometimes it can present with neurological syndromes, like they could be seizures or fits in a patient. So that is why it's very important to understand all this, that it's not only the lymph glands, it could be B symptoms, or it could be depending on the organ involved. Now, lymphomas can sometimes, rarely even present as emergencies. Again, it entirely depends on the size and the position of these lymphatic glands, which are there all throughout our body. And there are hundreds of them, maybe 600 to 700 glands in our entire body, human body. Now, suppose these glands are very close to the airway tracts, then they can be enlarged and press upon them and cause compressive symptoms and lead to airway obstruction rarely. So the patients can come with breathing difficulty, or they can present with cough, or they can have stridor, which there may be a sound while breathing, and there might be an emergency. It can compress upon the veins in the chest, and that can lead to what is a very serious emergency called as superior vena cava obstruction. They can compress upon the biliary channels or on the portal vein, and that can lead to obstructive jaundice. Then if there is associated increase in the IgM, that leads to hyperviscosity syndromes, which lead to terrible headaches, and they can be neurological syndromes. They can be fall in hemoglobin and fall in platelets, which can be autoimmune associated with lymphomas. So those can also be rare presentations. These patients have a defective immune system, so they have increased susceptibility to infections. Sometimes the lymphomas are so aggressive that there is a natural tendency for the cells to lyse, and that can lead to a kidney dysfunction, and these patients can present with what we call as a tumor lysis syndrome. Now, as I mentioned, there could be brain involvement, rarely within lymphoma of the central nervous system. Now, how do we diagnose lymphomas? We mentioned that symptoms may overlap with less serious illness. So how do we make a diagnosis? So one thing is very certain, that a procedure called a fine needle aspiration is not to be done. In fact, it's a big mistake if we do FNA of the lymph nodes, if you are suspecting lymphoma. The only way we can answer or diagnose lymphoma properly is through excisional lymph node biopsy, which means we excise an involved suspected lymph node completely, so that we can, under the microscope, study it and then come to a conclusive diagnosis, which is very critical for a patient of lymphoma. FNAC is not at all useful, as I mentioned. It has only limited role in certain settings, like when we suspect a breast cancer and a lump in the breast, or in thyroid cancers particularly. So that's where the role is, never in a case of lymphoma. Now, how do we stage lymphoma. What is very important again is that once the lymph node is seen by the pathologist under the microscope, we additionally need to do some tests to arrive at a conclusive diagnosis and exact diagnosis that is known as immunohistochemistry, which is very, very paramount in reaching to a conclusion. So that is something that has to be done. Now, once we have diagnosed a case, and then we need to stage it, that we need to know what is the staging of the disease. That depends on the extent of involvement. Some of it we can do on a clinical examination on all the nodes which are superficial. So if it is only one region of the node, it is stage 1. If there are 2 regions involved, like in the neck and in the armpit or in the chest, then it's stage 2. But if it is, across in the chest and the abdomen, and that becomes a stage 3, and any involvement of the bones, bone marrow, liver, lungs, that becomes a stage 4 disease. Now obviously what we cannot see the internal position of the internal lymph nodes, so for that we need to do imaging, and the best modality to do in these patients is what we call as a PET-CT. So it combines PET along with the CT imaging, where we come to know using a glucose stacked to a radioactive dye as to which lymph nodes and which region in a known case of lymphoma. The other test that is done for staging is the bone marrow biopsy. Besides that, we need to do many other diagnostic ancillary tests which help us not only in understanding some prognostic markers, but also to understand the tolerance to treatment in that given patient. So we do need to screen whether they are diabetic or whether the heart is okay, the kidney is okay, the liver functions are all right. We need to do some tests like serum LDH and beta-2 microglobulin and albumin to understand how likely the patient is going to fare with the treatment. Now, are the lymphomas treatable? Yes. All lymphomas at any stage are treatable. In fact, lymphomas are potentially curable. So when we talk about cure and malignancy, it means that the disease has been not only treated and responded, but there's a good chance that they are gone forever. So lymphomas are potentially curable. Now, the entire response of lymphomas depends on which is the subtype and also the staging of the lymphoma along with the age of the patient. So in the worst case scenario, if the patient is old and has a stage 4 disease, even then 50 to 60% of the lymphomas are still curable. So that is the message, that never give up. We've treated patients who've been on ventilators and they have come out and they're living normally. So we never give up on a lymphoma. We try to offer treatment to everybody because lymphoma is one of the most treatable and potentially curable malignancy. Now, what is the treatment of lymphoma? The treatment essentially comprises of chemotherapy and radiotherapy. Again, depending on the various subtypes, the treatment is tailored according to that. But surgery typically has no role in the treatment of lymphomas. They are only done for diagnostic purposes. As I said, excisional lymph node biopsy is done, and that is purely for diagnostic purposes. Now, in Hodgkin's lymphoma, we have a different chemo. As I said, the classical is treated differently from the lymphocyte predominant non-Hodgkin's lymphoma, and then we treat non-Hodgkin's B and T cell in a different manner. And then different subtypes are treated in a different aggressive manner. Now, all said and done, if we look at overall picture, the B cell lymphomas, we have specific drugs added, which are known as, these B cell lymphomas express an antigen on them, which is known as CD20. And we have a monoclonal antibody against the CD20 antigen expressed on the tumor cells. And this is added to the chemotherapy, which is makes it as a combined chemoimmunotherapy, which is offered for B cell non-Hodgkin's lymphoma. So what is the survival of patients with lymphoma? The survival of lymphomas, I feel Hodgkin's lymphoma is actually a success story in the treatment of malignancies. In early detected Hodgkin's lymphoma, the survivals are up to 80 to 90%. So these patients do very well if they are picked up early. Even if it is a stage 4 disease with comorbidities and advanced stage, these patients still tend to do okay, and their survivals are about 50%. Non-Hodgkin's lymphoma, the B cell non-Hodgkin's lymphoma, out of which DLBCL is the most common, these patients, it is potentially curable in about 50 to 60% of the patients. Now, more than 90% people have good responses to their initial treatments. And it's about 10 to about 15% of the people who are refractory to the chemotherapy upfront. And these are our problematic patients. But most of the patients do well. Now, these patients have a chance to relapse, as in the disease can come back later, and the ones who have responded. So that is why I'm talking about the survival rates of 80 to 90% or 50% in different settings. So these patients who relapse, there is, I think, a lot of hope right now. There's a lot of research where we have done genomics and we mapped them, and we are trying to personalize the treatments. But the mainstay of relapse lymphomas is high dose therapy followed by autologous stem cell transplant, wherein before giving high dose therapy we do the stem cell collection of the patient, and his or her own stem cells are given as a rescue after the high dose therapy. Now, this can be curative in many of these relapsed lymphomas, but a few of these patients may still not do well. These are exciting times as many drugs are being added to the, and there is a changing landscape of the entire lymphoma in the relapse setting. Newer monoclonal antibodies, PD-1 blockade, newer drugs, and the most exciting of it is the CAR T cell therapy, which is out there. So we are doing a lot is being done through the world through research and genomics, which is going to essentially make treatments of lymphoma in the future very, very tailored and personalized. So these are certainly exciting times, and we do hope in the future we'll be able to cure most of our lymphoma patients. Is there anything that you can do to prevent a lymphoma? Well, no. If we look at our patients, a few of our patients are some of the survivors of other cancers who have received chemoradiation in the past, but most of the patients we do not find any reason as to why they got a lymphoma. So the entire secret lies in picking them early so that we can cure them. So it's very important that we be aware of the symptoms of lymphoma that we have discussed today. Anything that is there is not scary unless it is persistent and progressive and unexplained. So, if these symptoms are there, if there is a lymph node, I think we must insist that there is an excisional biopsy of that lymph node so that the diagnosis is precise and crisp, and the treatments are according to the diagnosis and not empirical. Everything out there and an enlarged lymph node is not tuberculosis. Tuberculosis is one of the commonest causes of lymph node enlargement in our country, but not everything is tuberculosis. So we need to have the lymph node excised and perform IHC to reach a conclusive diagnosis. So pick it up early, be aware, pick it up early, and nip it at the bud, and have a success story in every case. That is the message, and I hope I've been able to share with you my entire feeling on this. The lymphomas are potentially curable, and we must attempt to catch them early by being more. Thank you so much.